Hello friends, let us now learn some important points about polycystic ovarian disease or polycystic ovarian syndrome, also called as Steen-Leventhal syndrome. So, in this Steen-Leventhal syndrome, the basic pathology in this is increased androgen production. Whatever the reason is, here most commonly there will be increased androgen production. This increased androgen production will first leads to hirsutism. This increased androgen stimulates the growth of sexual terminal hair, resulting in hirsutism. Then this increased androgen undergoes peripherally we have aromatase enzyme. In the presence of this aromatase enzyme, this androgen gets converted to estrogen. When this androgen gets converted to estrogen, this estrogen has three effects. 1. Estrogen can decrease follicle stimulating hormone. Once it decreases follicle, why does it decrease follicle stimulating hormone? So, increased estrogen is actually produced from ovary. Ovary produces estrogen. This production of estrogen by ovary is activated by follicle stimulating hormone, which is produced by pituitary. So, if estrogen is increased in any reason, due to any reason, if estrogen is increased, then it exerts negative feedback mechanism on follicle stimulating hormone. Thus, there is decreased follicle stimulating hormone. Once there is decreased follicle stimulating hormone, if you do a ratio of luteinizing hormone to follicle stimulating hormone, normally it is 1:2. But in patients with PCOD, this luteinizing hormone to follicle stimulating hormone ratio will be more than 2:1. Fine. This increased estrogen will have negative feedback on follicle stimulating hormone, whereas this estrogen has positive feedback on luteinizing hormone, and thus increasing the action of luteinizing hormone. Now, this luteinizing hormone is increased. When this luteinizing hormone is increased, first thing is there is no LH surge. Normally, whenever there is increased LH surge, that causes an ovulation. You can ask me, there is increased luteinizing hormone. That means there is increased luteinizing, that means there is LH surge. But this increased luteinizing hormone is constant. There is constant continuous increase in luteinizing hormone. But in LH surge, there will be increase in luteinizing hormone at a strike, like suddenly, and then it falls. This is LH surge. But here, there is continuous increase in luteinizing hormone. This absence of LH surge will cause an ovulation. Ovulation mainly occurs due to LH surge. Once there is no LH surge, there is no ovulation. Now, when there is no ovulation, this will decrease the progesterone levels. Ovulation will lead to increased progesterones. But because there is no ovulation, there is decreased progesterone levels. Overall, this will lead to, in the beginning, there will be oligomenorrhea. But slowly, as the days progresses, this disease progresses to secondary amenorrhea. Right. Then, this LH hormone will cause one more cause. We'll have one more issue. See, because of this LH, increased LH, this increased LH also stimulates theca cells. Because LH stimulates theca cells, this theca cells will undergo hypertrophy and they will produce androgens again. And this leads to increased androgens overall because of theca cell hypertrophy. Then, right, there is an ovulation. Very good. If there is an ovulation, then what about the eggs which are to be released? Normally, every month there will be one egg which is released, one follicle which is released. But if there is an ovulation, there will be formation of multiple follicles in the ovary. And among these, one will grow to a bigger size and it will form Graafian follicle, and that is released outside. But in PCOD, there is no formation of Graafian follicle. So there will be multiple cysts will remain in the ovary due to this anovulation. So in PCOD, you see the follicles are converted to multiple cysts in the ovary. Right? Next. Then, if there is increased androgens, now there is increased estrogens. Increased estrogen will act on the endometrium and it causes endometrial hyperplasia. As days progresses, this endometrial hyperplasia will convert into endometrial hyperplasia with atypia, and finally it can cause endometrial cancer, and this will also predispose to breast carcinoma also. Right. Then this PCOD, there is one more important thing. This PCOD also alters the lipid profile. It alters the lipid profile and it increases the LDL and decreases HDL, and thus it will lead to cardiovascular risk factors. That is, in future it can cause or it can lead to heart disease. Right? Now, one important thing is when there is increased androgens. There is one more important thing. Whenever there is increased androgens, this increased androgens will inhibit a hormone, a protein actually. This increased androgens will inhibit a protein called as serum sex hormone binding globulin. Okay, when it inhibits the protein serum sex hormone binding globulin production, this will result in increased insulin. This will result in insulin resistance. Because of this insulin resistance, this will predispose a patient with polycystic ovarian disease to diabetes mellitus. So this is the main thing that happens in PCOD. Right. There is one more thing. Right. Because of this increased or altered lipid profile, this will cause obesity in the patient. Okay. Because of this excess obesity, this can lead to mood changes and depression. And this can also lead to, this obesity can also cause sleep apnea, especially obstructive sleep apnea. The increased risk of obstructive sleep apnea is also seen in these patients. Fine. So, if you see the clinical features, it's nothing but whatever is here. So, a woman of middle-aged woman comes to us with history of menstrual irregularity, that is primarily irregular cycles and amenorrhea. And you can observe that the patient is obese and there is history of hirsutism, that is acne, alopecia is seen. And you will see that on lipid profile examination, you see there is altered lipid profile and there is insulin resistance. So, that is the clinical picture. There is one important thing that occurs in PCOD, which is called as Kantosis Nigricans. Kantosis nigricans is pigmented linear marks which you see in the neck and axilla are seen in Kantosis nigricans. These Kantosis nigricans occur due to insulin resistance. Insulin resistance leads to this Kantosis nigricans. Right. Then, what are the hormonal changes that you see in PCOD? See, in PCOD there will be increased androgens, number one. That is, there will be increased testosterone, increased androstenedione, and increased dihydroxyepiandrosterone. Then there will be increased luteinizing hormone. There is increased estrogen. And because of this insulin resistance, insulin will not act on peripheral tissues. So there will be increased insulin which is present in our body because it is not going to act on the peripheral tissues. So there will be increased insulin and there will be increased LDL, low density lipoproteins. So what are increased in PCOD? There will be increased androgens, increased estrogens, increased luteinizing hormone, and increased insulin, and increased low density lipoprotein is seen in luteinizing hormone. That what are decreased in polycystic ovarian disease? In polycystic ovarian disease, there will be decreased follicle stimulating hormone. There will be androgens will inhibit sex hormone binding globulin. So sex hormone binding globulin is decreased, and there will be decreased progesterone, okay, and there will be decreased HDL. So in polycystic ovarian disease, you see there is decreased sex hormone binding globulin, decreased follicle stimulating hormone, decreased HDL, and decreased progesterone. Then, if you were asked about the long-term consequences of this polycystic ovarian disease, what are the long-term consequences due to this polycystic ovarian disease? In the long term, because of this altered lipid profile, this will cause increased CVS risk factors, especially coronary artery disease increases in the patient. On long term, because of insulin resistance, there is increased risk of diabetes mellitus in the future. Due to increased estrogen, there is increased risk of endometrial carcinoma and also breast carcinoma is noted in the future. Then, because the patient becomes obese, there is increased risk of sleep apnea, and also there will be mood changes and depression. These mood changes and depression are also attributed to estrogen. Estrogen and decreased progesterone also causes mood changes and depression. And there is one important long-term consequence which is not there in this chart, that is non-alcoholic steatohepatitis. Non-alcoholic steatohepatitis is also long-term risk factor of polycystic ovarian disease. Right. Now, what about the diagnostic criteria? So, the diagnostic criteria, we have a name for this diagnostic criteria, that is Rotterdam Criteria. This is Rotterdam Criteria. According to this Rotterdam Criteria 2003, first, there will be symptoms of oligomenorrhea or amenorrhea are seen. Then, clinically, the patient will have increased serum testosterone will be diagnosed, or that is first clinical evidence. The first criteria is symptoms, that is presence of oligomenorrhea or amenorrhea. Second symptom is clinical plus biochemical symptom. Okay, in clinical symptom, we have the patient will have hirsutism or acne or alopecia comes under clinical symptom. Whereas in biochemical symptom, we have increased serum testosterone. Actually, this serum testosterone levels should be between 70 to 150 nanogram per deciliter. These should not be more than 200 nanogram per deciliter. If the serum testosterone levels are more than 200 nanogram per deciliter, then we do not consider polycystic ovarian disease. Then what do we consider? If there is serum testosterone levels are more than 200 nanogram per deciliter, then we will consider presence of ovarian tumor rather than polycystic ovarian disease. So in polycystic ovarian disease, serum testosterone should be between 70 to 150 nanogram per deciliter. Then third criteria is radiology. That is, in USG, you will see presence of 2 or more cysts which are of size 2 to 9 mm. 12 or more cysts which are of size 2 to 9 mm, which is present in one or both ovaries, with ovaries more than 10 ml, that is enlarged ovaries. So these numbers are important. In USG, you will see 12 or presence of 12 or more cysts which are of 2 to 9 mm in diameter, present in one or both the ovaries, and each ovary is enlarged, that is more than 10 ml volume. So this is the Rotterdam Criteria, which includes clinical symptoms, then clinical and biochemical symptoms, then ultrasonography. Then, how are you going to treat these patients with PCOD? So, if a patient comes to you with PCOD, first line treatment is giving selective estrogen receptor modulator. So in this selective estrogen receptor modulator, we can give clomiphene citrate and tamoxifen and raloxifene. Fine, this is fine, but do you give them for first line? No, they are actually the first line for infertility. So this is, if the patient suffers from infertility with PCOD, then the first line is selective estrogen receptor modulators. If the patient suffers from PCOD, always ask her for weight reduction. And lifestyle modifications are the first line. First step you give the patient is to decrease obesity through weight reduction, lifestyle modifications and exercises. Even after that, if there is no, it does not resolve, and if there are irregular periods, then you should give OCPs, oral contraceptive pills. And if there is insulin resistance or hyperinsulinism, then you should give metformin. So treatment mainly depends upon the symptoms. If there is hirsutism, then you should give OCPs with clomiphene citrate. So the treatment mainly depends with the, you should give OCPs with cyproterone acetate. OCPs with cyproterone acetate. I'll write it properly. Cyproterone acetate. Okay. For hirsutism, you should give OCPs with cyproterone acetate. Okay. So PCOD, first line, you will do weight reduction and lifestyle modifications followed by you should give symptomatic treatment. For irregular periods, you should give OCPs. Okay, for insulin should be given, metformin should be given for insulin resistance. So you will treat it according to the symptoms. But if there is infertility with PCOD, in such cases, the first line is giving selective estrogen receptor modulators. Then following these selective estrogen receptor modulators, in these the drug of choice is clomiphene citrate. Okay, among these selective estrogen receptor modulators, drug of choice is clomiphene citrate. If the person cannot tolerate clomiphene citrate, then you give tamoxifen. Even if the person, okay, this raloxifene is not normally used. It is not generally used. Then, if you see the second line will be, you can use either gonadotropins or you can use LH and FSH injections can also be used. And if you see the third line, in third line, we can use leuprolide or goserelin can also be used. Third line is mainly GnRH analogs. So for PCOD with infertility, you can use selective estrogen receptor modulator and second line drugs like gonadotropins and LH-FSH injections can be given, and you can also use gonadotropin releasing hormone analogs. But then, if even after doing everything, if still this does not resolve, then you should do surgery. And in the surgery for PCOS, we have laparoscopic ovarian drilling, where you will pass a monopolar cautery into the ovary. This is the ovary with polycysts, many cysts. Then you will pass a monopolar cautery into the ovary and destroy the ovarian theca. All the theca, you will destroy it. So this is about the polycystic ovarian disease. Thank you guys for watching my lecture. Thank you.